And part two of our lecture today will involve antithrombotic therapies and also their lab assessments. So what are the anticoagulants that we can use with thrombotic disorders? So we'll discuss some of the common anticoagulants and the not so common, and some of the laboratory tests that we use to determine the levels and to monitor anticoagulant therapy. So one of the major anticoagulants is warfarin, otherwise known as Coumadin, and this is the oldest type of oral anticoagulant. It works to inhibit clotting. It is monitored by using the prothrombin time test and the INR, which also stands for International Normalized Ratio. The INR has a very narrow therapeutic range, and so it could either be an INR of 2 to 3 for those with a DVT or a pulmonary embolism, and an INR of 2.5 to 3.5 for those with a mechanical heart valve who are on Coumadin. It is very important to closely monitor the Coumadin levels or the warfarin levels using the PT test. And so this is a routine test. It's easy to do. The INR will be given to you automatically because of its calculated formulation in the instrument. So an INR less than 2 signifies that the patient is at risk of clotting, and an INR greater than 4, it signifies that the patient may be at risk of bleeding. So those INRs need, therapeutic anticoagulants need to be greatly monitored, and also in this particular case they need to be adjusted. So one of the things that we need to remember is that the warfarin therapy, or Coumadin as an oral anticoagulant, is the way that it works is that it's a vitamin K antagonist, right? So this type of therapy is greatly affected by diet. So vitamin K in the diet actually decreases the effectiveness of warfarin or Coumadin. Where do we get vitamin K in our diet? Well, we get it from green leafy vegetables, green tea, cauliflower, lots of avocados. Certain supplements have vitamin K in them. Certain drugs have vitamin K in them. So when they are put in this kind of anticoagulant, patients are advised to maintain a regular diet and not so much vitamin K, because what Coumadin wants to do is like it wants to take away the effects of vitamin K, right? So if you want to add more to that, then we have an issue. So basically, the diet is very important when someone is put here in Coumadin. Also, in the presence of a lupus anticoagulant or in the presence of a coagulation factor deficiency, it is difficult to identify the PT levels, okay? But if we want to get the PT levels with an INR, okay, we can use a test called the chromogenic factor 10 assay, okay? And we say that because sometimes lupus anticoagulants or certain factor deficiencies can interfere with a PT. In those cases, we can use the chromogenic factor 10 assay. I'll talk about that in the next slide. And therapeutic range target for the factor 10A activity should be about 20 to 40%. So the chromogenic factor 10 assay is, again, a test that we can use in cases where the patient has a factor deficiency or a lupus anticoagulant and we cannot use the PT and INR. We can use this test to monitor for Coumadin therapy. The patient's plasma with factor 10 is added to reagent factor, activated factor 9, activated factor 7, calcium, phospholipid, and a chromogenic substrate. Activated factor 9, activated factor 5, calcium, phospholipid, then activate the patient's factor 10 to 10A. Once it gets added, we want to activate the patient's factor 10 to 10A. The substrate is it's at first colorless, but then when it binds the PNA, it releases free PNA, which is yellow in color, and it is measured at 405 nanometers, 405 nanometers. The intensity of the color is directly proportional to the concentration of factor 10 in the patient's plasma. A calibration curve is then constructed using dilutions of PNP. So monitoring warfarin anticoagulant therapy, especially for those patients that have a lupus anticoagulant, which can interfere with the baseline PT and the INR. With this, we can use this assay, the factor 10 chromogenic activity assay. This assay should not be used for monitoring heparin or oral direct factor 10A inhibitors like Xarelto or Eliquis, or Saveza. So it's very important. So the methodology here is chromogenic, and the reporting name is factor 10 chromogenic activity assay, okay? That's different than the heparin assay, so that's just something to keep in mind. All right, so if you can remember how warfarin works, warfarin, again, it's the oldest excuse me, the oldest type of anticoagulant, right? Of oral anticoagulant. And so warfarin begins to affect the syntheses. The way it works is that it begins to affect the syntheses of vitamin K dependent factors such as prothrombin, factor 7, factor 9, 10, and the inhibitors such as protein C and protein S in about 12 to 24 hours. As you can remember, vitamin K is responsible for the gamma carboxylation of these factors, and this carboxylation enables these coagulation factors to bind to calcium. So without vitamin K, we have production of non-functional factors, prothrombin, 7, 9, 10, protein C, and protein S. And so coumadin is known as a vitamin K antagonist that suppresses gamma carboxylation by slowing the activity of the enzyme vitamin K epoxide reductase. Warfarin does not achieve the full antithrombotic effect until about 5 days of dosing the patient. And factor 7 is the first factor to be affected because factor 7 has the shortest half-life. And that is why the common test to monitor warfarin or coumadin is the PT and the INR, because the PT primarily tests for factor 7. Okay, so here are the time required to obtain about 50% of normal after starting coumadin. So basically, at about 6 hours after starting coumadin, factor 7 will be decreased to about 20%. In 24 hours, factor 9 about 30%. In 30 hours, factor 10 at 25%. In 60 hours, prothrombin at about 20%. So the coumadin therapeutic range, what we want is an INR of 2 to 3. Or if we're using the factor 10 activity chromogenic assay, then we want it to be at 20 to 40%. To repeat, the patient will achieve full anticoagulation in coumadin or warfarin within 5 days. However, levels of protein C and protein S, which are also vitamin K dependent, also decrease. So that's something that we need to keep in mind. So in acute thrombosis, unfractionated heparin or low molecular weight heparin is given for the first 5 days until coumadin takes effect, because it will take 5 days. If you have an acute thrombotic event, you don't have 5 days to treat it. So it has to be, the patient needs to be given something that will work a little faster. So how do we monitor once we put the patients on coumadin? Well, you will monitor the PT and INR at first 24 hours after the first dose. then the PT and INR daily until 2 consecutive results end in the therapeutic range. So let's say an INR of 2 to 3. And then once you get to that range, you can you can monitor using the PT and INR every 4 to 12 weeks until the patient is done with the therapy. The next major anticoagulant is the unfractionated heparin. So this is another one that you will hear a lot about in coag. So Coumadin or unfractionated heparin. Sometimes it's just referred to as heparin. But there's two types of heparin. There is unfractionated heparin and low molecular weight heparin. So again, heparin is also known as unfractionated heparin, and it is a naturally occurring glycosaminoglycan, okay? So since heparins depend on the activity of antithrombin, they are considered to be anticoagulants. And so they are specifically used in things like treatment of heart attacks, stable angina, and things like that. Typically, it is a drug that is administered intravenously, but it can also be given to someone subcutaneously. People metabolize heparin in the liver, and they excrete heparin in the urine. All right, so basically that's just one of the majors. But what we want here with heparin is that we want to decrease the clotting ability of the blood and help prevent any harmful clots from forming in the blood vessels, okay? Sometimes you'll hear people say, I'm taking a blood thinner. There are many different types of blood thinners, but heparin is a type of blood thinner. So the intravenous route and subcutaneous route are actually some of the most common routes that the one can have heparin in. So basically, again, an inhibitor of coag, it's a heparin. Heparin is a catalyst that activates antithrombin to neutralize serine proteases. It binds to antithrombin. So heparin relies heavily on antithrombin so that it can act as an anticoagulant. In order to avoid HIT, right, which is a thrombotic disorder, sometimes patients are placed in low molecular weight heparin. I'll explain that in a little bit. Heparin is monitored by the APTT test. That's a common way of monitoring heparin. And we want to achieve a therapeutic range for APTT, and that must be equivalent to 0.3 to 0.7 international units per ml of heparin as measured by the chromogenic anti-factor 10A assay, also known as the heparin assay or the heparin anti-10A assay, okay? So not to be confused with the chromogenic factor 10A assay. So we use this test to measure heparin and to establish a therapeutic range for the APTT. So basically, we are going to set that in our lab. So this way we have a range, a therapeutic range for patients that are actually taking heparin. We want them to be within this therapeutic range. And so the chromogenic anti-10A factor assay measures the ability of heparin in the patient's plasma to complex with antithrombin and to neutralize factor 10A in the reagent, okay? So I have an image here which explains the procedure. And so this is how the chromogenic anti-factor 10A assay, heparin assay, or factor assay or heparin assay works. The chromogenic anti-factor 10A assay measures the ability of heparin in the patient's plasma to complex with antithrombin. And the whole point is to neutralize activated factor 10A in the reagent, okay? So we want heparin and antithrombin to form a complex, okay? And once it forms a nice complex, this can complex, or it can neutralize activated factor 10A in the reagent. So basically, the reagent is a mix of antithrombin and a measured excess of activated factor 10A. Most kits do not provide antithrombin and rely solely on patient plasma antithrombin. So again, antithrombin binds heparin, and this complex binds to activated factor 10A. Excess free factor 10A, which you will see here, okay, digests its substrate to produce a colored end product, okay, and the color intensity is inversely proportional to the plasma heparin that we have for this particular patient. So this assay, again, is used for monitoring fractionated heparin and low molecular heparin and also other forms. So to recap, the intensity of the color is indirectly proportional to the concentration of heparin, whether it's low molecular weight heparin or fractionated heparin. A hypercalibration curve is constructed that can be used for both anticoagulants, but the therapeutic range can be a little bit different for unfractionated heparin and low molecular weight heparin. So the therapeutic range for heparin using the chromogenic anti-factor 10A assay or the heparin assay is 0.3 to 0.7 units, international units per ml of plasma. And so we need to determine this therapeutic range for the APTT. So we want to match the seconds to the 0.3 to 0.7. So what we do is we take specimens. We take the specimens, APTTs, and we measure the APTT for a baseline amount. Then specimens are taken for 4 to 6 hours after the initial administration of unfractionated heparin, and then repeated every 24 hours. And also when the patient is on heparin, we make sure that the platelets are checked every day, right, to avoid HIP. But the way that we set this therapeutic range is we take 50 plasma samples of patients on heparin therapy, and we analyze those samples by both the APTT and also the heparin assay. Then we take all of those results and we plot them, okay? So the heparin will be plotted on the x-axis. So you'll see there the anti-10A, anti-factor 10A assay. And then the APTT is plotted in seconds in the y-axis. So you can see the APTT right over here, and then the APTT, the anti-factor 10A activity assay right over here. So basically, we determine the APTT values that correlate with 0.3 to 0.7. So it would be anything in between this, all right? And so basically, a therapeutic range for someone who is on heparin can be anywhere between here, like 65 to like 80, 85 or something like that. And so the APTT is going to be slightly prolonged because these patients are on heparin, but it's still within that range that we want them to reach. So here's a recap of our anticoagulants, are common anticoagulants. So we use the PT to monitor for the warfarin or Coumadin therapy, which is typically an oral therapy, and the APTT to monitor the APT tests and to monitor the therapeutic ranges for people that are on unfractionated heparin or low molecular weight heparin. Okay, so now I want to explain what low molecular weight heparin is. And low molecular weight heparin, it's kind of like it's a derivative of unfractionated heparin, but it's smaller in size, and it has a more predictable response in patients. So we can actually calculate the dose that we need to give them based on the patient weight. Low molecular weight heparin is a little easier to use. We don't usually need to monitor except for patients who are pregnant or maybe that have kidney disease. Another reason why people use it a lot is because it can be given subcutaneously, and also it can be administered to the patient, by the patient at their own home. So this is something that they can deal with a little bit easier. But when patients are in the hospital, they're usually given unfractionated heparin. Low molecular weight heparin also has greater bioavailability, in which there is less nonspecific binding to cell surfaces and proteins. It has a longer half-life than a fractionated heparin and lower incidence of HIT, which is very, very important. So here's some examples of low molecular weight heparin. So Fragmin, Lovenox are some examples of those. And this is how low molecular weight heparin basically works in our system. So as you can see here in the picture, is that low molecular weight heparin inhibits coagulation by activating antithrombin. Antithrombin binds to and inhibits activated factor 10 or factor 10A. And in doing so, it prevents the activation of the final common pathway, right? Which is factor 10A activation, which means that prothrombin is not activated to thrombin, thereby not converting fibrinogen into fibrin for the formation of a fibrin clot. So again, low molecular weight heparin is a small fragment of a larger mucopolysaccharide, which is the unfractionated heparin. And again, heparin works in a similar way by binding antithrombin and activating it. So both of these, the administration of either one, either heparin, fractionated or low molecular weight, it really depends on the patient, the condition that they're trying to treat, the setting of the patient. It depends on the contraindications and also in some of the adverse effects of the actual drug. But it's very important to also keep in mind drug-to-drug interaction. So what are the other drugs that the patient's taking is something that we must consider. Okay, so basically, the heparin assay is actually the only test that we can use if we want to monitor low molecular weight heparin accurately. Most of the time, the APTT will be done for unfractionated, and the chromogenic anti-factor 10A assay for low molecular weight, although sometimes they do monitor low molecular weight using the APTT. But it does not, it's known that the APTT cannot be used because it does not prolong the APTT. So we stick to the chromogenic anti-factor 10A assay when we know the patient is in low molecular weight heparin. And so, we also use this test when we want to determine the or monitor unfractionated heparin in the presence of a lupus anticoagulant. So again, the therapeutic range should be 0.3 to 0.7, and for low molecular, that's for heparin, for unfractionated, but for low molecular weight, it's about 0.5 to 1.2 units per ml. And the specimen's taking 4 hours after the subcutaneous injection. The prophylactic range of low molecular weight is 0.2 to 0.5 units per ml. Just keep in mind that when you test and monitor for this, the plasma must be separated from the cells within an hour. Otherwise, platelet factor 4 will be released by platelets and it will bind heparin and decrease the plasma concentration. And so our common anticoagulants are here. We have vitamin K antagonists, which are Coumadin or warfarin. We can use the PT and the INR. In cases where there is a factor deficiency or a circulating lupus anticoagulant, you may use the chromogenic factor 10 assay. For heparins, we have fractionated, and that's given intravenously or by injection. And we use the APTT or the chromogenic anti-factor 10A assay, and low molecular weight heparin is given subcutaneously, and it can be monitored using the chromogenic anti-factor 10A. Some others are listed here. Anticoagulants can also be direct thrombin inhibitors, and here are some examples: Novostan, Argatra, Angiomax. Pradaxa, which is an oral form. There are also direct factor 10A inhibitors like Xarelto, Eliquis. There are also antiplatelet agents like aspirin, clopidogrel, and antifibrinolytic agents. So these lyse the clots that are already present. And some of that, and we talked about this briefly, is the tissue fibrinogen activator. And this is a recombinant TPA that is administered within 3 hours of an acute ischemic stroke. It activates plasminogen in the clot to restore blood flow and minimize brain damage. A CT scan is done to rule out a hemorrhagic stroke in which the patient is bleeding. And in this case, tissue plasminogen activator is not used or is contraindicated because it can result in a fatal ischemic event if that is the case. You want to rule out bleeding abnormalities when you administer tissue plasminogen activator. So it is contraindicated when the platelets are lower than 100,000, when the PT is elevated, and when the INR is greater than 1.7, when heparin has been administered within the last 48 hours, and also when the APTT has been prolonged. So there's some considerations to take before TPA is administered, but it's actually a very important drug in cases of ischemic strokes to prevent any brain damage. Okay, so with that, I will end this lecture. This is the lecture that we had on thrombotic disorders and their lab assessments, and also on antithrombotics or anticoagulants and their lab assessments. If you have any questions, please let me know. As always, I'm here, and thank you so much for watching the video.